ladies and gentlemen, esteemed guests and distinguished panelists and speakers. I'm honored to welcome you today to the Global Forum on Refugee Health, held by the Global Health Institute at the American University of Beirut. Thank you for taking the time to join us. Today we are honored to have with us Dr. Zahir Dawi, the Provost of the American University of Beirut, and Dr. Shadi Saleh, the Founding Director of the Global Health Institute at the American University of Beirut. We are also pleased to be joined online by our key partners, ELRA and the World Health Organization headquarters in Geneva. My name is Dalia Sariyuddin, and I am a project coordinator at the Refugee Health Program at GHI, and I will be the master of ceremony for this significant event. This forum aims to provide a unique platform for researchers, policymakers, and humanitarian practitioners to discuss solutions for bridging the gap between research, policy, and practice in refugee health. We will start with opening remarks from Dr. Dawi, followed by Dr. Saleh. Next, we will have presentations highlighting our journey to impact at the Refugee Health Program at GHI, followed by presentations from our key partners at ELRA and the World Health Organization, who will also share global perspectives on research uptake. Finally, we will engage in a moderated panel discussion with experts in the humanitarian field who will also offer diverse perspectives and insights on bridging the gap between research, policy, and practice in humanitarian contexts. Starting with the opening remarks, Dr. Dawi, the floor is yours.
Thank you so much. Good morning. I'm happy to be with you today. I'll try to be as brief as I can. I know you have a very rich program. Thank you, Dr. Saleh, GHI team, for organizing this forum and inviting me to be part of it. Refugee health, a global crisis in need of local solutions. The theme of today's forum is so timely and relevant. The UNHCR reported recently a peak of 120 million people forcibly displaced around the world, mostly in the global south. A record high, double the number that we had just a decade ago. So it went all the way up from 60 to 120 million in 10 years. So if you look today, 1 in every 69 people, or 1.5% of the entire world's population, is forcibly displaced. Forcibly displaced communities live inside and outside camps, in informal settlements and built environments in their own and other countries. Irrespective, studies have certainly shown that they are exposed to significantly increased public health risks and livelihood vulnerabilities, with limited access to healthcare and well-being services. In many instances, these challenges do extend as well to the host communities. So I want us to think today more broadly about refugee health as refugee and host community health. Towards solutions and interventions, which is again a key component of this forum, the path forward has to be embedded in locally driven contextual research and innovation that shape evidence-based policy and practice that in turn help educate and empower the target communities. And here again I underline the essential role of the target communities in any intervention. This human-centered research, policy, practice, education, empowerment chain aligns perfectly with the core elements of our mission here at the American University of Beirut. Since the founding of the university in 1866, AUB has been a university for all, and service for the public good has been ingrained in our DNA. Back to refugee health, the biggest challenges become how to access, how to scale, and very importantly, how to sustain, how we can make sure whatever interventions, solutions are implemented, how can these sustain over the long term. So we have to learn from the short term to curate a more effective long term. We have to learn from our own experiences. We have to meet, share, debate, plan, and work together. And this is what the Global Health Institute is facilitating today and tomorrow through convening an outstanding cohort, and I'm very happy to see the room full, of experts, educators, thought leaders, partners, and community members. I wish you all a most engaging and enriching Refugee Health Forum. Thank you.
Thank you, Dr. Dawi. We will now hear from Dr. Saleh.
Good morning, everyone. Good morning to a packed room, which indicates how significant the problem is. The refugee health as a program is very dear to my heart because GHI was started in 2017, and the first program that we initiated was the refugee health program. For many, many have questioned whether we will have a sustained refugee program or problem that would ensure that a refugee health program will continue to exist. And that was in 2017. And here we are today, 7 to 8 years after we started the program, approximately 12 years after the Syrian crisis started, approximately 75 years after the Palestinian crisis started, and we're still talking about the issue of refugee health. Just to give you an example, and my colleague Hadi will speak about this more globally, as our provost said, there are around 115 to 120 million refugees around the world. And 20 to 25% are concentrated in our region. So we're talking about a region that has a total of 300 to 350 million individuals. Imagine the number of millions of people who are displaced or refugees. So hence, it seems like, unfortunately, and especially now with what we are witnessing regionally with the Gaza war, globally with the Ukraine war and many other wars, the issue or the problem of refugee health will continue to be a global health issue. So this is first. Then my second point, and I will conclude with that, is we in academia, our biggest challenge is trying to translate the research that we do in an institution such as AUB, translate that into research and policy. Okay. We have dedicated policy institutes at the institution. Our partners, the Isam Faris Institute, and Joe will be speaking later today. But I think in self-criticism, we also have to continue to do more on making our work, our interests have more impact when it comes to policy and when it comes to actual practice. Unfortunately, early on, we learned the difficult lesson that in Lebanon, as in many parts of the world, translating evidence into policy is faced with many challenges, including, or most important of which, is politics, right? Policy is about politics. And our colleague from UNHCR is living that perhaps more acutely these days. But that is the fact of the matter. However, our role as an academic institution, as I dare to say, the premier academic institution in Lebanon and in the region, to support whatever we advocate with evidence. And this is what we have tried to do with the refugee health program, as you will see shortly. Lastly, I want to thank you for coming over. I know it's a hot and a humid day. I want to thank our partners, ELRA, UNHCR, the World Health Organization, the headquarters and regional office, as well as the Lebanon office. And I hope that today would be a day where we think together more and more on how to translate evidence into policy and impact. Thank you. يعطيكم العافية.
Thank you, Dr. Saleh. Thank you, Dr. Dawi. We will now proceed with our first presentation, providing an overview of our refugee health program at GHI and highlighting our ongoing journey to impact in improving refugee health. This will be presented by the Programs Division Manager at GHI, Mr. Hadi Naal. Mr. Hadi, the floor is yours.
Good morning, everyone. And thank you for coming today. So my name is Hadi, and I manage the Research and Policy Programs Division at GHI. Before we dive deeper into our topic today of exploring solutions to bridge the gap between research, policy, and practice in the context of refugee health, which we're pleased to have our partners from ELRA, WHO, Geneva, and EMRO and UNHCR and others who will be covering that. I would like to give you some background on the challenges associated with the health of refugees and displaced populations. And I'd like to introduce the Refugee Health Program at GHI, whose team is hosting this event. So ensuring good health, well-being, and dignified living for refugees is a global challenge. As the numbers of refugees and displaced populations are increasing worldwide, especially in the MENA region, given its endemic state of conflict. There are an estimated over 115 million refugees worldwide, and over 14 million in the MENA region. And with this, refugees tend to experience unique challenges that disproportionately affect them in relation to the general population. And this includes war-related trauma, inadequate access to good nutrition and access to clean water, acculturation challenges, among many others. And these factors increase their risk of developing diseases and illnesses, many of which are preventable, especially that they also lack good access to healthcare services such as medications, treatments, and so on. So basically, improving refugee health requires contextualized and sensitive solutions that are sensitive to their needs. So it's in this context that the Refugee Health Program was incepted in 2017 under the programs division at GHI. And the Refugee Health Program is basically a multidisciplinary program that aims to explore and respond to the impact of protracted crises on the health and well-being of displaced and refugee populations, so not only in the Middle East, but also in the global South. And the Refugee Health Program, RHP, operates through three interlinked arms, which are research, so to produce knowledge and evidence, policy, to influence decision-making, and community support to engage and work directly with affected communities. So with this in mind, over the past 7 years, the Refugee Health Program has worked on multiple projects, and now I will walk you through some of them. So first, we have the R4HC project, which we worked on in partnership with King's College, Imperial College, Cambridge University, among others. And the aim of this project was to strengthen health research capacity and to better address the health challenges in conflict-affected settings. So we worked in multiple countries, including Libya, occupied Palestinian territories, Turkey, Jordan, Lebanon, and so on. Under this project, we conducted multiple capacity strengthening sessions that aimed to improve the use of political economy analysis among professionals working in this region. We also produced 2 policy-oriented documents analyzing the interplay between politics and economics on health in Lebanon. And these documents were very important to better understand the landscape of healthcare in Lebanon, especially given how the political and economical climate is very challenging to work in. And we also produced multiple evidence-driven policy recommendations to strengthen the healthcare system in Lebanon. And finally, under R4HC project, we also produced a special issue with the Journal of Global Health that focused on the political economy of health in conflict-affected settings, which also included 8 manuscripts on this topic. So next we worked as part of a multi-country consortium with the World Bank, UNHCR, and Columbia University to produce a report aimed at understanding how health systems in Jordan, DRC, Bangladesh, and Colombia have responded to crises that led to forced displacement and subsequently that focused on the health needs of displaced populations in these countries. So in addition to the policy-oriented work that I already mentioned, we also partnered with WHO EMRO to develop and deliver 3 courses focusing on migrants and refugee health in the Eastern Mediterranean region. So as part of this project, we delivered these courses to multiple cohorts online, and we reached 155 learners who are public health professionals, academics, or researchers working with ministries of public health, UN agencies, humanitarian organizations, universities, and others. And these courses were important, had important implications on their work as they exposed them to knowledge and best practices that they could adopt to better respond to emerging health emergencies in the Eastern Mediterranean region. So our work with refugees also included a flagship project under, for GHI called Sijilli. And Sijilli, literally, translated in Arabic, literally means my record. Sijilli is a cloud-based electronic health record program created in partnership with Epic Systems. Sijilli was able to overcome a key issue in refugee health, which is to ensure that refugees have direct and secure access to their medical records wherever they are in the world, and for them to be able to share it with their healthcare providers wherever they end up during or after their migration journey. Sijilli has reached so far over 10,000 refugees across all governorates in Lebanon, whereby we collected comprehensive data from them, including their lifestyle habits, their vaccination and medical histories, and so on. So what's important here is that this project, so far, we were able to establish proof of concept for Sijilli. However, the project, or Sijilli, was designed with the understanding that it has global utility for refugees and displaced populations worldwide. Finally, through the Mobile University for Health, our work also included training refugee women living in vulnerable settings and preparing them to assume the role of community health workers within their communities. So what's special about this project is that it was delivered to them, so it followed a mobile approach, whereby it improved their access to health education and allowed us to overcome many barriers that are traditionally associated with their access to health education, including transportation challenges and so on. Under MUH, we developed and delivered 4 certificates that are contextualized to the needs of refugees, both in terms of their content and in terms of the delivery approach. And those certificates focused on women's health, mental health, NCDs, and infection prevention and control. So in 3 years, MUH trained over 80 community health workers and prepared them to be able to raise awareness about health, to promote good health and good health behavior. And we also, through MUH, managed to create communities of practice, whereby these community health workers went on to lead formal health events to disseminate, to further disseminate this knowledge within their communities. So in conclusion, under RHP, we've worked on multiple projects. We produced over 20 scholarly and policy-oriented documents, and we trained over 300 professionals and community health workers. We've also worked with many partners throughout the years, including from UN agencies, humanitarian organizations, and academic institutions, among others. So to end this presentation, currently what we're working on is a project in partnership with WHO and ELRA, which is called the Self-Efficacy and Knowledge Trial, SEEK. In this project, we will evaluate an intervention, an integrated intervention that aims to improve family planning, sexual reproductive health, and well-being among refugee women and girls. And this will be done through an RCT, where we are preparing to conduct an outcome and a process evaluation to examine both the effectiveness of the intervention and also its feasibility and acceptability. But I'll leave the discussion on SEEK for another time. I will end here. Thank you very much for your attention.
Thank you, Hadi. We will now move into the second section of our presentations, providing global perspectives and invaluable insights on research uptake in humanitarian contexts. We will first hear from Ms. Cordelia Lonsdale. Ms. Lonsdale is the Senior Research Impact Advisor for Research for Health in Humanitarian Crises, short for R2HC, and which is a research funding program at ELRA, a global humanitarian organization based in the United Kingdom. Ms. Lonsdale helps R2HC grantees to strategically engage and communicate their research to policy, practice, and community stakeholders, overseeing the evaluation of research impact and promoting evidence uptake. With 7 years of experience in the international development sector, Ms. Lonsdale has a track record in global development policy research and advocacy. Ms. Lonsdale, thank you for being with us today. The floor is yours.
Thank you so much, Dalia. I'm not able to share my slides at the moment. But in the meantime, let me just thank the Global Health Institute and AUB for inviting me to speak. It's a real honor, and I'm very much looking forward to the discussion. Let me try again. It looks like I can share now. Are you able to see those slides now? If I just
yes, we can see your screen now.
Wonderful. Okay. Yes, so I was asked to come and speak about research uptake in humanitarian context. So as Dalia said, I work for ELRA, which is a global organization that finds solutions to complex humanitarian problems through research and innovation. And specifically, I work for R2HC, the Research for Health in Humanitarian Crises program. And I think some of you will know it well. The aim of the program is to improve health outcomes for people affected by humanitarian crises by strengthening the evidence base for public health interventions. As you can see there, we're a research funder with an impact mandate. And so that means that as a program, we need to go a little bit beyond just funding grants and then stepping back. So this is why we as a program have invested a bit of time not only in funding and supporting grants directly, but also in trying to understand the humanitarian sector and the landscape of evidence use and work out how we can best support and promote research uptake. So I wanted to share some of what we've learned to hopefully frame that discussion a bit for you today. I was going to cover very briefly the challenge in terms of barriers to research uptake in humanitarian settings, then share a little bit about what we're doing as the funder, the contributions that we're trying to make and support our grantees to make, and then finally just pick up on some of the opportunities that we see more broadly for the humanitarian system and the humanitarian research system in particular to improve uptake and use of evidence in humanitarian response. So I think actually some of the previous speakers have covered a bit the challenge, so I won't go into too much detail here. I think you've all seen some of the numbers around the scale of global humanitarian needs, and we've talked about specifically the numbers of refugees and internally displaced persons today, all adding up to a big dollar sign, a big dollar requirement there, and a lot of humanitarian needs, as we all know, also go unmet. So in that context, humanitarian crises contribute to ill health and vulnerability, undermining health systems as well. And we know that despite, we've made a lot of progress in the past 10 years with the support of partners like AUB in terms of addressing the evidence gaps that we have, but overall the evidence base is still weak and patchy in certain areas. So there are gaps that we need to fill. And what this means today is that still humanitarian and public health actors working to support refugees and internally displaced persons still lack evidence to inform policy and practice decisions. But we're also not necessarily using and applying the evidence that we have today. So I wanted to share this image, which is, it comes from a paper a learning paper that we produced in 2020, I think it was. And this is the pathway for research uptake and impact in humanitarian settings. So if you start at the bottom of this image, where you have researchers and their partners producing research and disseminating and communicating findings, you can see here there's a few different routes that it can take to the top. So if you see the top, which is where humanitarian interventions are improved and people affected by crisis will get better outcomes, you can go a number of different ways. So you can see researchers and their partners using findings to do more research, build a body of evidence, and then perhaps sharing that with delivery actors, INGOs, agencies, governments, to integrate that into standards and guidelines. You might then see those standards and guidelines eventually embedded in humanitarian training and tools. And then finally, you get improved interventions. You might also see direct application of those findings in policy and practice, but that's usually just in that study setting, and then you need to go through that same pathway to get the improved interventions. Finally, you might also see evidence brokers picking up that research and synthesizing it, communicating it, sharing that with donors and those same agencies and so forth. So the key points that I want to make with this is that this pathway for research uptake and impact, from findings to eventually people feeling the benefits, is not a linear pathway. There are multiple steps. Multiple stakeholders need to be involved, including evidence or knowledge brokers, and really you need research findings to be combined and synthesized with other evidence or other information in order to be used and applied. You're not seeing one single research study that is changing policy over the long term, most typically. It also means that producing and disseminating papers is only the first step on the pathway, and it won't lead to uptake and impact on its own, which I'm sure most people in this room already know and have experienced. So walking that pathway is challenging. It's challenging in any setting, right? And there's a famous statistic that floats around saying that it takes, on average, 17 years for research findings to reach clinical practice in settings like the US and UK, where it's relatively stable and the system is relatively kind of predictable and you know who to engage with and so on. In humanitarian settings, there are some specific barriers, and this is again from that same learning paper I mentioned, where we did a literature review and did key informant interviews with a range of humanitarian stakeholders from a variety of different settings, and we identified 4 barriers to uptake. The first barrier is around time, so not only time constraints for all the actors involved, but also mismatched timelines. Research perhaps taking longer, or the results being available at the wrong time for when humanitarian actors might need to make a decision, that type of thing. So time is one. Secondly, and I'm sure we're all acutely aware of this sometimes, is the resource constraints that exist, particularly on the humanitarian side, in terms of just having those evidence brokers or people available to engage with evidence, to translate research evidence. All of this takes time and it takes money. There's a point about relevance as well. So research evidence isn't always felt to be relevant to the realities of humanitarian operations, what practitioners are facing in the field. For example, we know from a review of MHPSS research that sometimes the interventions that are most studied are not the interventions that are mostly being used. So there can sometimes be either a real or perceived lack of relevance, and this sometimes comes back to the research not being translated in the right way, so that its relevance is obvious to those who might want to use it. And what was interesting in this paper is we also saw that this was particularly acutely felt where the research was produced by those in the global north, but it was designed to be applied and used by humanitarian actors that were in the global south. So there was a disconnect in terms of the perceived relevance in in that kind of case in particular, where it was felt that the research wasn't addressing the needs that were being articulated. And I'm sure again this is something that everyone in this room will have seen discussed plenty of times. So from the perspective of a grant maker, from a funder, we've been putting in place changes and improvements in our program over the years in the way we fund and support research to try and support our grantees to address some of these challenges directly. We have always tried to fund research questions that respond to humanitarian needs, and we try and get a better sense of this by funding and supporting research gap analysis and priority setting exercises that consult humanitarian stakeholders, and also by addressing this in our calls for proposals. We fund research practice partnerships by design, so partnerships that include humanitarian actors, and since 2019 we've also made it mandatory that all grants we fund must include a partner from the context or the country where the crisis is taking place. We ask applicants to set out their impact objectives and their plans for research uptake with their proposals. We also ask that all study teams have to appoint a research uptake focal point, because doing all of this work doesn't happen on its own. It requires dedicated capacity and skills, competencies and expertise. And we ask grantees to allocate a grant budget line for research uptake that is sufficient to cover all of those activities. We provide support, as I think Hadi was mentioning, support for our grantees to actually plan for uptake, create and deliver those uptake and dissemination plans, and support amplify those key findings, especially where they might be significant outside the setting, to try and support with communications and webinars, campaigns and so forth. We've also been recently piloting uptake and impact small grants, because sometimes you don't know where you don't know what the opportunities are going to be at the end of a study when you're starting out, and we were finding that grantees were coming to the end of studies with these new opportunities or really promising engagements with policy and practice stakeholders. So we've been awarding small grants to allow grantees to go that little bit further with their engagement at the end of studies. And finally, evaluating the uptake and impact of research, so producing case studies to better understand how research uptake happens. This is informing the development of tools and guidance that we can share more widely, and I wanted to flag one in particular, which is our research impact framework. This is a tool we hope other researchers and funders can use, and it outlines the 5 strategies and 9 enablers of research uptake and impact in humanitarian settings. And that's drawing on analysis of 20 research impact case studies from our portfolio. So hopefully we can share a link to that in my slides afterwards. And finally, this is my final slide. I hope I'm doing okay for time. We can't do this all on our own. R2HC is a relatively small actor, and we're looking to see bigger changes in the humanitarian system, and particularly in humanitarian research across the ecosystem. So on the supply side of research, we'd really like to see more attention overall to funding and supporting both research and practice experts who are closer to the crisis. We know this is an enabler of research uptake, not only because of the relevant expertise that these experts have, but also they are positioned close to policy and practice actors who can use and apply the research and are better positioned to navigate and understand the entry points for change and work with them over the long term. And that brings me to my next point, which is about longer term programs, so covering the whole research to practice pathway. We know that producing and scaling innovative approaches means that you need to take a long-term approach, so funding that whole pathway. We need to make better use of humanitarian data, tap into practitioner and community expertise in study designs, and I'll quickly wrap up and just move to on the use side, so on the humanitarian system. I'd like to see more attention to strengthening humanitarian demand for evidence, so attention to systems, culture and leadership of evidence use practice. more support for humanitarian learning and evidence translation on the humanitarian side, and more spaces and platforms for research and practice knowledge exchange. So I think that's me finished, and there's some further reading here that I hope we can share afterwards. I look forward to the discussion. Thank you.
Thank you, Ms. Lonsdale, for that insightful presentation. Next, we will hear from Dr. Lali Say. Dr. Say works at the Department of Sexual and Reproductive Health and Research at the World Health Organization headquarters in Geneva, heading the unit on integration of sexual and reproductive health with health systems. Dr. Say is also the acting head for the Research Leadership and Knowledge Management Unit and holds a medical degree and has specialist training in reproductive health epidemiology. Dr. Say has worked at the World Health Organization since 2002, initially managing global monitoring and evaluation activities. Dr. Say, thank you for joining us today. The floor is yours. Dr. Say, I think you need to unmute yourself.
Thank you very much, Dalia, for the introduction, and thank you very much for GHI for the invitation. I'm very pleased to be part of this forum, and not only because, as Hadi mentioned, that we have been collaborating with GHI since now 6-7 years, but also GHI contributes a lot to WHO's work and tools and standards and guidance, and very happy to be partnering with this with colleagues here. So let me share my slides. So I'm going to also touch base some of the higher level issues in terms of research uptake in humanitarian context from a global perspective. And Cordelia has very eloquently focused and very specifically focused on humanitarian research uptake in humanitarian context. But I will start maybe from the broader research uptake from the global for across the stable settings, which has been also challenging, and in humanitarian context, further challenges are added on the research uptake aspects in general globally. So what do we mean? We all know what we mean, but just maybe to have a common understanding that research uptake or translation of knowledge translation, knowledge transfer, many words or many descriptions on this issue, but it's actually the use of research findings by multiple stakeholders, policymakers, program managers, funders like ELRA has been doing very well, and health workers. Has been a key concern for the past 2-3 decades, and there has been a plethora of literature in how best to do this. Still, we don't know how best to do this. And there has been a multiplicity of frameworks that is being proposed or brought forward in terms of helping the uptake of research findings by policies and programs. We also see a lot of research on research uptake, how best to uptake research. There's a lot of also learnings from that research during the past years. But again, as we all know and mentioned by Cordelia, there is no single strategy. Whatever we do, whatever active efforts we do for research uptake, it needs contextualization. But regardless of all the efforts needed, we are all in agreement that, and WHO recommends that, evidence-informed decision-making has a key role in improving the effectiveness, efficacy, and equity of health policies and implementation. This guidance is a WHO guidance for evidence-informed decision-making by both policies and programs, but also by researchers themselves. That was published in 2001 and has some important or some interesting frameworks or considerations for us all. Again, why we need a focus on research uptake, we may not need to justify. Cordelia mentioned the 17 years that is closely cited, etc. And again, you know, as mentioned, we all know, even if it's very relevant, applicable, or convincing, it doesn't automatically drive changes in policy and practice. Our findings automatically doesn't drive. So we have to do something that is active, that is deliberate, and that is systematic if we want to improve and increase the impact of our findings in our research to help people's health. This is in 2014, 10-year study. It's a little bit old, but still it's interesting. I put here, the World Bank conducted a study that assessed a selected group of knowledge products, research findings, reports, or papers published. And 87% of those selected products were never cited in other research or policy documents. Only 13% was taken and cited. We don't even know whether or not they are applied, but they were cited, only 13 of them. And again, in healthcare and clinical research, practice change from knowledge transfer activities have been reported only at 8 to 15%. This is again, as I said, there's so many frameworks, so many studies, understanding or framing the barriers, facilitators of research uptake. This is one of them. Not specific to humanitarian settings, for across-the-board stable settings, stable context. But again, we see a lot of dimensions that needs to be assessed and understood and addressed if we want to really do a deliberate attempt for research uptake. I'm not going to go through them one by one in the interest of time, but I believe slides will be available after the meeting for people who are interested. And this is the specific to humanitarian context. Again, it was mentioned, most of them are mentioned in Cordelia's presentation. In addition to all other barriers, we also have in humanitarian context the constraints due to violence, insecurity, logistical, the gaps in service delivery, inflexible funding, human resource gaps, more than other settings, sometimes and maybe usually weak coordination, fragmented leadership, and others. And I also would like to refer to this table from the document, the WHO document on evidence policy impact document that I showed in my first slide, as the factors facilitating research uptake that we can consider if we want to if we are concerned of uptake of our research, and if we want to make a plan for the uptake of our research when we are embarking on a research. These are related to organizational resources, the characteristics of policymakers and practitioners, our target audience, usually for the research uptake, the characteristics of research itself and researchers, policy characteristics, and finally contact and relationship between research producers and users. And here, as we are mostly researchers and we are really considering how best our research may be uptaken by policy and programs, I would like to draw your attention to the third and fifth columns. One of them is research and researcher characteristics. The research has to be timely, clear, high quality, multidisciplinary. It should be relevant to policy and practice. It should use user-friendly formats in communicating from the beginning the reason for our research and the findings of our research. And the researchers actually need to have a good understanding of policy processes and context. And the fifth column also draws attention to contact and relationship between research producers and users. And it's really very nicely fits into Cordelia's last slide about the demand and supply. So there has to be collaboration and co-production with the users from the beginning. There has to be timing, and the research has to time opportune times for research to policy processes. There has to be an understanding and learning about different cultures, language, processes, and of course mutual trust and respect. So we as researchers in humanitarian context, we may need to ask some questions before even we have a question to research, or before even we are conceptualizing a research project. So one is what is the role of research community in addressing the impacts of humanitarian crisis in the setting that the research is planned to be conducted? How can research help improve the quality of services during and after crisis? Are there important specific questions that can only be addressed by research in this context? Or we can also address some of things, maybe without doing research. And how do researchers work in these challenging settings? There may be already an ongoing, very intensive humanitarian assistance, and how these two aims or objectives can fit or can conflict. And what are the successful, equitable, and sustainable research collaborations with local researchers, with regional researchers? And is there an advocacy role for health researchers? And one scoping review recently published in 2023 has found some common gaps in a number of studies that have assessed in terms of implementation of research findings in policy and practice in humanitarian context. So some of the common gaps are found as implementing the engagement of implementing actors after research is produced, not at the beginning or during the research. The second thing is because the interventions to be tested or to be assessed, or delivery modalities to be tested or assessed, needed to be flexible. So we have to be really contextualizing the intervention delivery if we are doing research around that. There has been disruptions that affect how research findings can lead to sustained practices. For frontline actors to be engaged in research and to take the research findings, there has to be strong leadership and stable resources. It has been seen as difficult to create a safe learning space to discuss challenges during both conduct of research and research uptake activities. Feasibility in such settings needs to be balanced, and communities and frontline actors need to be engaged as early as possible, as mentioned several times. My last few slides on a few examples from WHO's current efforts, how we actually move ahead, or how we actually promote uptake of some of the research findings or evidence-based practices. Of course, as WHO, as you know, our biggest mandate and role is to develop standards, guidelines to improve clinical and policy practice. But not even not in humanitarian settings, for the stable settings, there has been this concern of WHO produces so many tools, so many guidelines, nobody uses them, it's not used. So this is actually an ongoing concern for WHO as well. So we have been doing specific efforts on promoting the use of WHO guidelines and the evidence included in the guidelines. But in addition to that, we also are doing specific efforts to adapt the guidelines to humanitarian settings. This is an example. Our flagship guideline on contraception, medical eligibility criteria for contraception and contraceptive delivery guidelines. We have developed a process, a systematic process to adapt the contraceptive guidelines for humanitarian settings. This is being done through a defined process and with the consensus of a number of stakeholders that really considered of ensuring the follow-up of, for example, the follow-up of clients after having a contraceptive delivery, or the application of different contraceptive methods in humanitarian settings. So it's an adaptation of existing WHO guideline. The SEEK intervention package mentioned by Hadi, so that's another intervention that is developed using existing evidence, but now we are trying to get more evidence in how best to implement SEEK intervention package. And an earlier publication from 2018-19, I guess, is a research priority setting for SRH and maternal newborn child health in humanitarian settings. So these are some of the things that we really, specific to humanitarian settings, we incorporate, we compile evidence and try to promote their uptake. Two things I wanted to also highlight. One of them is the platform SRHR and UHC Learning by Sharing portal. Here we are including case studies or successful research results to incorporate in this platform that have actually improved service delivery across the world. But we also have a specific section on the humanitarian setting. So this is a way, perhaps aiming to help researchers and policymakers or research teams to share a story about their successes that can be included in WHO's platform that can help informing other research, similar research in other areas. And finally, the other guidance is a preliminary guidance. It's almost a work in progress, but we issued a preliminary guidance for a package of high priority health services for humanitarian response, H3 package. So this is an adaptation of the WHO's compendium of effective health interventions in adaptation of them into a humanitarian context, and it's called H3 package. So these are some of the things that we aim the researchers, the research findings across the world can be integrated, and which amplifies their use and their uptake. Finally, another example from DRC, where we actually did a multi-method, using multi-method methodology and analysis for integrated SRH service delivery, and immediately translated that to service delivery together with policymakers and partners, and especially UNFPA, and UNHCR. So my final notes actually is just a few notes, but as we all know them, I know in this audience everyone knows it, but just for us to reiterate. So we have to think about the research impact before, during, and after the research across the whole process. We have to identify all relevant stakeholders, again from the beginning, including frontline actors, and co-develop the research. We have to have actually a real engagement of affected communities, not a lip service, but a really thorough engagement of affected communities. We have to focus where the translation evidence from non-crisis settings cannot be made. So if, you know, what is specific, what cannot be translated to humanitarian context. So research questions can focus around that. Again, mentioned in the opening remarks that there has to be a focus on assessing interventions that have a potential for delivering at scale. And finally, this is something I know, again, everyone knows, but really it's very important to build and engage in large networks to share and disseminate results.
Thank you, Dr. Say.
Thank you very much.
Thank you for your time. Thank you for your presentation. So we will now open the floor for questions from the audience in case there is any before taking coffee break.
Before we start the Q&A, I just want to acknowledge another very important partner that we have within AEB, which is also the Asfari Institute for Civil Society. They have been with us on that path, so I want to thank them and acknowledge the director who is with us also, Dr. Lina Abu Habib. So back to the Q&A, Dalia.
Thank you. So we're opening the floor for questions from the audience in case you have any. Yes.
Hello everyone, I'm very pleased I'm here. My question is for Hadi actually, because you talked about Sijili and you talked about SEEK. Let me introduce myself. My name is Mariana Ramadan Makarim. I'm from NRC, Norwegian Refugee Council, and I'm the project manager for the legal protection project, which is called ICLA. We have been working on child marriages and dealing with girls who don't know nothing about reproductive health, who have no idea that with marriage comes, you know, sleeping with the husband. And due to that, we have a lot of rape cases, and we have a lot of, you know, GBV, SGBV cases. How can we actually interlink between the research you guys are doing on reproductive health with what we're doing? Because those girls lack communication with those parents, and their mothers don't know what to tell them about reproductive health. That's one of my questions. The second question would be, will you be...
Sorry to cut you off, but it's okay to answer the first question first and then
Sure.
move on. So in terms of your question, this is a complicated question to answer. There's so many factors that we should be considering. A few things that come to mind. One of them is to ensure that the referral system is clear to them. So in case of reports of protection concerns, we would know where to refer them as humanitarian actors and as researchers working with them. So that would be the first point. The second point that I would mention is that through the interactions that we do with them, so through the engagement and the work that we do with them, it would be also good to improve their communication skills so that they know how to work with these issues when they happen between the families, how to identify when a problem might arise and how to deal with it when it happens. But this is like a brief answer. I know this is a much more complicated topic and it requires a more complex answer to that.
Which takes me to my second question.
Yeah.
Will you be
But
thinking
just-
about a
excuse
more
me.
holistic approach?
this is just to follow up on what Hadi said. This is one of the reasons, what you just explained is one of the reasons or the objectives of the SEEK trial that we're doing, right? So this project that we're currently engaging with WHO and ELRA, one of the main thing is the whole issue of self-efficacy and training, and sort of training with soft skills, mostly younger women, on how to sort of deal with the whole sexual and reproductive health. So this is research that we're currently doing. Now we would be counting on you, not as a person, but as a sector, in order to help translate some of the things that we're finding, we're supporting into actual sort of practices, right? And that is why we're doing it. The site that we're doing this project in specifically are primary healthcare centers, right? So that the whole healthcare system is engaged. It's a safe practice. They know that we're doing it in a healthcare system. We're not trying to push or advocate for any agenda.
Thank you so much. I think that answered my second question and the holistic approach thing. Thanks.
Okay. Thank you.
Dr. Say in her presentation, she mentioned that only 13% of the research, let's say, outcome or studies are cited in other research papers or in other policy documents. And why is that? And how we're trying to address it? And also, like what you mentioned, like usually the outcome of the studies, like what you're now doing in SEEK, you're trying to integrate the outcomes and the humanitarian programs. Can you maybe just tell us how, or Dr. Say, like how as WHO or other actors you're addressing this?
It is, and I would like the provost also to contribute to this. لأنه نحن one of the, I don't mean to answer all of the questions, so probably this is the last one I answer. One of the problems that we have in academia is that we have been trained as researchers sometimes to do research just for the sake of research, right? And at the end of the day, we work for months and years on papers that 5 people read. And in the new neo-academia, this should not be the case, and this is what we're trying to do, and this is what we hopefully are trying to do as an institution, and this is the reason why we had this meeting actually, is that we as researchers have to do more in terms of focusing our research on practical issues, not research for the sake of research. And also policymakers and practitioners have also to take into consideration that some of the research or evidence can be sort of used in their practice. So I think it's a two-way street. Definitely as universities around the world, and not only in Lebanon, we haven't been doing a good job in moving from the model of research just for the sake of research and promotion and etc. And the other side should also do that. So, Abarf, if you had anything to add.
No, thank you. I fully agree, and there is that gap between research and research translation, and this requires cultural change in the academia, I would say, because it relates to how faculty members have been trained, it relates to how evaluation systems are set in place. As a university, we have been emphasizing a lot knowledge translation. We have launched several initiatives to push research into policy and into affecting practice. I think the work that GHI is doing is a role model in that space. And even more recently, through the institutes, the Asfari Institute, Issam Faris Institute, we have also pushing multiple initiatives to engage communities and affect policies. And we have more recently also launched what we call governmental engagement platform, which is a new initiative at AUB that would allow the university, through the researchers, to engage with the government in the broad sense. Could be the government and non-governmental organizations that work with governments, so that we can translate as much as possible from the research work that happens at the university to policies and eventually to legislation that can be sustainable on the long term. So it's a big theme in academia, And there is, I think, as administration, we have a role to play on that front. And very good question. Thank you. Thank you, Shadi.
Hello. Zainab Hanna from Amal Association. Thanks first for the invitation and for the great work that JHI is always doing, because it's always picking up on topics that are hands-on and make sure to really respond to the actual need with a big benefit. I'd just like to highlight that Amal Association have tapped into the same component, and we have founded a research department inside Amal for the same purpose of ensuring that we analyze the data that we're collecting through the service provision. We analyze it and we come up with research paper to disseminate, to guide our programs and everybody's program forward for the findings that we get on the large scale, but also to impact policies and advice on advocacy and way forward. And we have seen with the protracted crisis that in the past 5 years, really, Lebanon faced all type of emergencies, and that the pattern are changing very, very quickly. So I think this combination of having the humanitarian actors with academia is such a wonderful cooperation that could bring a lot to humanity and make sure that we respond to exact questions, and in many times in a very cost-effective way. And Dr. Saleh spoke about sexual reproductive health. We have to say that really in the PHCCs, we are seeing how much really the prevention is helping. The more we put effort into prevention, the more we are able to decrease the cost of tertiary care, hospitalization, and at the same time, lots of components where we are tackling and studying the multidisciplinarity component, whereby addressing health. In many places, we have seen many people after the explosion going to AGP in a time where they need mental health support. So also this is stressing our resources for things that could be addressed in a multiple way. Amal is a big proponent for having midwives in the PHC, despite that the accreditation of the MOPH does not require that. And we have 14 midwives in our PHC, and it has proved how much prenatal and antenatal care is addressed to a very high level. So I think those are the type of questions that we could raise. Malnutrition has been a big issue that we're studying. Pediatrics are now measuring the PUAC, etc. So thanks a lot for this initiative. I think we can do a lot. Something to note that after the crisis, before more refugees were coming to PHCs, now we have more Lebanese coming, which the middle class is disappearing. And this is something to note and to study very well. And we know that health is an entry point to all the social, psychosocial, all the other apparatus that brings the better well-being. So we're happy to all cooperate forward.
Leil or Cordelia, do you have anything to add to the topic? Leil. Lali.
Yeah, thank you so much. There is a drilling happening in my house just now, so I couldn't catch some of the questions at the beginning, so I'm so sorry, but I can always respond by typing, or if needed, respond, anytime if repeated. But there is one question in the comments asking how important the mixed method research in humanitarian settings is. Really, I mean, that's maybe one of the most important things, as we mentioned. Several issues that are so important in not ensuring, but trying to make sure our research is impactful. The community engagement, the inclusion of multiple stakeholders, but also more important than the contextual issues. We really need to capture the contextual issues, the barriers, the facilitators, and we can only capture these through, for example, qualitative research methods, even if we do a quantitative study. So that's a very quick response to that. But if there was any quick question, if it can be repeated, I can try answering that I missed.
Okay, I don't think there are any other burning questions at this point. Cordelia, did you have anything that you would like to add?
Yes, thanks. Just to add to the great comments that have been coming from the audience, I just wanted to pick up on, I think, Dr. Sadi, the aims that you were talking about, going, researchers needing to go beyond research and engage with policy and practice more. I couldn't agree more. But I do think that you can't do it all on your own, right? And obviously you talked about the humanitarian sector also needing to we talked about strengthening demand, but I just wanted to pick up on the types of research as well. And there was a question I saw about mixed methods somewhere. So we, when we were doing our analysis of case studies, did find that mixed methods was definitely one of the strategies that could help lead to impact. But I think we are at the point now where we may need to look beyond that a little bit. And I mentioned study designs that can make better use of not only that, there's a huge amount of humanitarian data that I think one of the questioners was mentioning that, the use of internal data that needs to be made better use of. But actually that is really hard. A lot of it is kept internally within humanitarian organizations, isn't shared. They do their own evaluations that don't get shared externally, and then we go doing the same research again and again. And I just want to draw everyone's attention to a paper in Conflict and Health that came out recently calling for more implementation science in humanitarian settings. And the reason it hasn't been done so much is that the current frameworks and models in implementation science are really difficult to apply in the kind of complexities that Dr. Say was highlighting with the, shifting central leadership and constant disruptions and so on. But moving that agenda forward could perhaps get us to a point where we are not only testing interventions with RCTs and so on and making sure that they work, and moving one step forward into understanding how and why and where they work and what kind of adaptations need to be applied so that we can really push forward into scaling the interventions that work and getting them applied outside the settings where they're tested, which we do still really struggle with. So I think I'll stop there, but thanks so much for the great questions. Over.
Thank you, everyone. In the interest of time, we will take a 10-minute coffee break now, and we'll reconvene for the panel discussion. We will now proceed with the moderated panel discussion, and the moderator for our session is Dr. Gladys Hnen. Dr. Gladys. Okay, so Dr. Hnen is an associate professor at the Hariri School of Nursing at the American University of Beirut. Her research is focused on social determinants of health, especially among underprivileged populations. Dr. Hnen collaborates with interdisciplinary teams to develop innovative research guided by principles of equity, inclusiveness, and participatory approaches. Dr. Hnen also collaborates with Lebanon's Ministry of Public Health and the Order of Nurses on national capacity building efforts and the development of guidelines influencing policy and practice. Dr. Hnen is going to introduce the panel and then lead the discussion. Thank you, Dr. Hnen.
Thank you, Dalia, and good morning, everybody. It's such a great pleasure to see a full room, actually more than one room, filled with people who are interested in translating research into practice, which is really close to our hearts. If we want to make impact, as Provost Dawi mentioned, if we're going to make impact, we need to start working with an intention to implement rather than to publish as we do as academicians. So I think what we discussed, the presenters discussed, is sure enough to tell us that there is a problem when we are translating research into practice. And this is in general, not talking about refugee health, which they have really very specific context. And also we're talking about the host communities like Lebanon who are hosting refugees, and we have our own challenges, never mind the refugees as well on top of it. So the challenges are many, but what we're trying to do as much as possible to address the priorities. So for that purpose, and thankfully for our panelists in here and virtually, who represent different stakeholders in terms of research, practice, policy, and decision makers, funders, and also kind of decision makers at the regional level, for joining us today to have this discussion. So allow me, first of all, to introduce our panelists. I'm just going to briefly talk about their biographies. So we start with Dr. Ali Ardalan. Dr. Ali Ardalan is a regional advisor and head of Health System Resilience Unit at WHO Regional Office of EMRO, with a focus on integrating health systems and health emergency risk management. health system recovery from emergency, humanitarian, development, peace nexus, and the health of refugees and migrants. He's a public health professional with about 20 years of experience at various managerial, policy-making, advisory, and academic capacities. Dr. Ardalan was the founding chair and professor at the Department of Disaster Public Health at Tehran University of Medical Science. He is a senior fellow at Harvard Humanitarian Initiative and a visiting scientist at Harvard School of Public Health. Thank you, Dr. Ali Ardalan, for joining us. Dr. Renda Hamidi, no need to introduce you, but I know you. I have to. Dr. Renda Hamidi is an internationally renowned public health expert and the director of Primary Healthcare and Social Health Department, the manager of the Immunization and Essential Drugs Program at the Lebanese Ministry of Public Health in Lebanon, and she's leading the primary healthcare agenda in Lebanon, and she's doing an amazing job. We have to learn from her. Dr. Hamidi also steers the immunization program in Lebanon, which provides vaccination services to all children in Lebanon, including children from refugee families. She has expertise in program design and implementation in complex settings, so she has the right expertise in that sense. And she also she has expertise in integrated service delivery, supply chain management of vaccine and drugs, and the policy framework around PHC and immunization. Dr. Hamidi is currently managing a complex national program serving both the host communities and one of the highest number of refugees per capita, as you know, in Lebanon. So thank you, Dr. Hamidi, for taking the time to join us. I know how busy you are. Dr. Zina Sultana. Dr. Zina Sultana is also a distinguished public health professional with extensive experience in managing health programs for refugees. Currently, she's serving as the Senior Public Health Officer at the UNHCR in Beirut, Lebanon. She leads comprehensive healthcare programs, ensuring optimal resource utilization and strategic coordination with key stakeholders. Dr. Sultana holds a Master of Science in International Health from UCL and a diploma in Tropical Medicine and Public Health. Her career spans various roles across multiple countries, so she has really extensive experience, I guess, in refugees' health in specific as well. She worked in Egypt, Ethiopia, Rwanda, and she works on different topics, including nutrition, emergency response. She also contributes to research, which is great, including studies on multi-drug-resistant tuberculosis and family planning among refugees. And she highlights her commitment to evidence-based practice and policy development. So she's the right person in the right place. Her dedication to public health is further evidenced by active participation in international forums. Dr. Sultana's leadership and technical expertise make her an invaluable panelist today. So again, thank you so much, Dr. Zina. Dr. Joseph Bahout. Dr. Joseph Bahout is the director of the Institute for Islam Affairs Institute at AUB. He's also an associate professor of practice in the PSPA department at AUB. He was a scholar at Carnegie Endowment in Washington, D.C., professor at Sciences Po Paris, and consultant to the Policy Planning Unit at the French MOFA. Prior to that, he was an assistant professor at USG and researcher at CERMOC. He also had political and consultancy activities with various ministries and public bodies in Lebanon. In France, he was a senior advisor to the SG of Académie Diplomatique Internationale. Bahout has been a fellow with the Crown Center for Middle East Studies at Brandeis University, with the Geneva Center for Security Policy, and a member of the scientific board of IFPO. He's the author of 2 books and of numerous articles and book chapters. He's a frequent commentator on international media. Obviously, he's a high-profile political sciences professor. Thank you, Dr. Bahout. Dr. Fuad, our colleague in the RHP, we miss you, Dr. Fuad, by the way, is a professor in social sciences and global health at Liverpool School of Tropical Medicine. He is the co-director of the Refugee Health Program at the Global Health Institute and a research fellow at Isam Faris Institute for Public Policy and International Affairs at AUB. Dr. Fuad's extensive research on migration and health, which includes on multidisciplinary approach to forced displacement, health system in humanitarian settings, and the political economy of health in protracted crisis. He underscores his expertise and commitment to addressing global health challenges. His role as a member of several technical working groups, including the WHO Global Consultation on the Health of Migrants and Refugees and the Global Health Research Agenda, he underscores his expertise and influence in the field. In his last decade, Dr. Fuad has worked as a professor of public health at the Faculty of Health Sciences at AUB. He was also the IDRC chair of the Forced Displacement Program in the Middle East, and he served as a commissioner in the UCL Lancet Commission on Migration and Health, and he is currently a commissioner in the Lancet Commission on Health, Conflict, and Forced Migration. Dr. Fuad is the author of more than 100 articles and reports published in top journals such as Lancet, PLOS, etc. Last but not least, Ms. Lina Abu Habib. She is our dearest colleague as well. She's the director of the Asfari Institute for Civil Society and Citizenship at AUB. She teaches undergraduates and graduate gender courses at the Faculty of Arts and Sciences. And she is the Gender Project Director for AUB MAPI TLS program. She currently serves on the board of the Urgent Action Fund and is the chair of the Doria Feminist Fund. Ms. Lina Abu Habib is also a member of the editorial committee of the Gender and Development journal published by Oxfam. She was previously executive director of Women Learning Partnership and before that the director of CRTD. She has worked extensively with the Royal Tropical Institute and with several international and regional organizations in the Middle East and North Africa region. She served as the secretary and then as the chair of the board of the Association for Women's Rights in Development. Ms. Abu Habib has considerable experience in feminist qualitative research, gender analysis, and training and facilitation, and writes regularly on the issue of care, work, citizenship, feminist recovery, and feminist movement in the MENA region. She was a PhD candidate at the Faculty of Applied Humanities Institute of Public Policy in Auckland. As a global gender consultant, Ms. Abu Habib worked in most countries of the MENA region, in West Africa, and the Caucasus. So this is a really brief introduction. I know it's probably a long biography, but then we had to introduce them to know how high profile they are. So without taking more time into the topic, I just want to start with Dr. Fuad. I know, Dr. Fuad, you are you're going to give us your practical experience on engaging stakeholders. So the idea of having this discussion with important stakeholders to set your research priorities. Can you give us some insights and the lessons learned that you have learned throughout the years in this program?
Well, good morning, Sabah al-Khair. You hear me well?
Yes, we do.
Excellent, excellent. Thank you. Really, I miss being in person, but unfortunately, I had some problem with the passport issue, so last minute. Anyway, so and thank you for inviting me, and thank you for raising this question, Gladys. I think this is, again, an important issue. Listening this morning to different presentation on exactly how to translate, all that work on research into more policies and practices. Speaking about stakeholders, and the engagement of stakeholders, and I guess the simple answer is yes, we need to engage stakeholders from the beginning, and being sure that this could address the needs of or the priorities of the community. But well, and we all know, researchers, practitioners, people working in advocacy, we all know that this is not the case, or at least this is not easy case. One of the issue is to define who are those stakeholders, and then forgive me if I raised more questions now. Are we talking about local stakeholders on the local level? Are we talking about national stakeholders on the national level, or international or regional? So we have like a, multi-stakeholders. But the issue is not about they are multi. Actually, the issue is that sometimes there should be, we found that there's some sort of lack of coordination, but sometimes even more. It's sort of the issue of compatibility, how people could, work together and fit it together. And some worse times, there's sort of a conflict of interest. One of, again, the other issue is about redefining, their roles and responsibilities. And one of the issues that in the last few years, talking about localization and the importance of engaging people and stakeholders, local stakeholders from the beginning, which is definitely important issue. But again, the devil is in the details, because, does it mean that localization is a sort of abandoning responsibility of the international communities, which sometimes actually is the case? I'll bring an example of a project that I work on now in Majd al-Andar in Bekaa Valley in Lebanon, about health system resilience. And the main core of this project is which is participatory approach project, is about engaging the local community. And what we did is we targeted the municipality to work on that. So, and working on what's called the municipality health committee. But then the many challenges that we face is a lot of conflict of interest, a lot of isolation sometimes from the center. So I guess maybe Shadi mentioned about the issue of politics. When talking about working sometimes in such a sort of context, politics actually emerge as a major issue to do that. And speaking about that, I think one of the issues when talking about researchers, academicians, that we, for a long time, we thought that this is just a technical issue, and ignoring, the issue of politics, the issue of economy, and given that sort of a less engagement. In this case, yes, we should do that, but the problem is how to do it. I will stop here. Sorry.
So, Dr. Fuad, how about engaging the policy who are influencing the decisions? Then, rather than having them as people who are influencing the policy and decision makers, why not to involve the politicians in this discussion from the outset? And in that way, you can have their buy-in.
Excellent. So let me back again with the question. Do you know how the decision is made in Lebanon? I think this is the issue. Yes. Sometimes, as a researcher, we like to write what we call the policy recommendation at the end of papers, and these are very important issues. But in reality, we don't know how the decision, or at least we know the decision is very complicated in some context. And then understanding how the decision is made is something very important to influence actually the implementation, the research uptake. And I do agree, yes, engaging them from the beginning, but who are them, and how to reach that issue in the right way.
Did we do so? No.
I'll stop here, sorry, I should say.
Yeah. Okay, well, this is interesting because honestly, you went through different points. It's like defining the stakeholders, defining the focus, whether it's going to be local, regional, or international, and also defining the factors that influence the decision making. Those need to be thought of at the beginning of any research if we really want to be having a good buy-in from research to practice. And this is a huge undertaking. Any further comments on this point, Dr. Fouad?
Yeah, I will leave it to the others, so if I can
Sure.
come back later. I know that they gave me like 5 minutes. I think I sit there.
Okay. So from engaging, just to conceptualize the research question to funding. So I'm going to move to Dr. Ali Ardalan, and the question is, given your role as a WHO MRO, and can you give us some insights on how international donors prioritize and earmark funding for translating research into practice? Dr. Ardalan.
Thank you so much, and good morning all. First of all, let me appreciate the Global Health Institute for another great initiative and organizing this forum and the opportunity given to me to meet old friends here. So the point is that the use of the evidence is being growingly recognized by almost all the stakeholders, including the donors. And however, there are some challenges that were elaborated by the speakers in the first section. Potentially, the donors are interested in evidence in different parts of their work, starting from the situation and needs assessment. When they want to define actually a project and prioritize that. They also need evidence to identify the interventions that basically being workable and useful in a particular context. And finally, it's about the measuring the impact with the focus on sustainability of impacts that usually most of the big like international donors are interested. They want to make sure that when the project is done, the impact will sustain somehow. There are actually good examples of our current work that we are doing that during the design of the projects or the activities, initiatives, the research evidence have been used. Of course, I will discuss about what more elaboration on the research itself and the evidence itself. But in general, taking the known evidence-based approaches into the consideration of the defining the projects. One of them is the current project we have under the Migration Multi-Partner Trust Fund. Is actually a project working, focusing on Lebanon, Iraq, and Jordan to linking the human mobility, climate change, and disaster risk reduction. And throughout the design and the defining of the projects and activities with the countries, basically the existing evidences have been reviewed and are being taken into the consideration. The other thing that usually the donors do and are interested in the context of the refugee and migration health is the donors that are supporting the ideas of the durable solutions for IDPs and returnees. For examples, for instance, in Somalia, in Afghanistan, etc. Integration with the host communities. We have example of actually supporting this type of the approach that are being recognized by the available evidences as useful by donors and the multilateral organizations, for instance, in Iraq. And many evidences are being used for designing the monitoring of disease trends, such as cholera surveillance, etc., in humanitarian setting. And what also my dear colleague Lale mentioned about those related to the, for instance, gender-based violence among refugees, among many others. However, all of us know that is not easy and straightforward as such. What we want is a research that is useful, usable, and used. But however, many factors that actually affect our our practice in the real world.
But Doctor, sorry, can I interrupt you? But then there is something, you know, when you have limited resources and you have so much funding that you need to be allocating, are the priorities set up from bottom up or from top to bottom? This is important, and this is if we want to be translating it into practice and policy, the people who are going to be implementing, they have to have a say in the funding and the priorities for those funding.
Oh, so this is so you mentioned that there is like a lot of fund. Usually, it's not like this.
Yes, exactly.
Usually in the real life, the financial resources are limited.
Yeah.
So the prioritization become much more important.
Mm-hmm.
As you rightly said, basically we need to have the opinion of the implementers and actually the end beneficiaries into the design. Among the parts, the projects that I mentioned as the example, for instance, the multi-partner trust fund, exactly it is happening. So the defining of the interventions with that limited fund available is being conducted with the close consultation with the implementers on the ground.
Okay, great.
However, always the point is that how this like a partnership participation is being done. So this is exactly can be we discuss in the maybe the next question part of the panel you have considered to how to monitor and measure this type of the considerations into the design of those projects. But you're absolutely right. So the top-down is something, and however the bottom-up approach needs to be there to ensure that the projects will have the maximum impact and will sustain.
Thank you.
I can stop here or continue, depends on my time. Over to you.
Okay, thank you so much, Dr. Ardalan. Now moving forward to the barriers in research uptake, and here I want to have the opinion of Dr. Zinia Sultana. As the head of the public health unit at UNHCR, definitely there are a lot of decisions that need to be made. So when you are making those decisions with regard to the implementation, what are some of the challenges for uptaking research as the main factor guiding your policy and decision makers?
Good morning again. Do you hear me well? Okay, the mic is working. Thank you firstly again to the organizers. I recall this is my second time in an event organized by JHI in the last couple of months. And thank you for highlighting the need for refugee health, not only locally, but globally. So I really appreciate the effort of the team. Thanks to the speakers, I also see very many familiar faces in the audience. Many of our partners, colleagues are here to attend the event, so it's a success I already see. So now in terms of the challenges barrier, let me quickly provide a brief on UNHCR engagement in research. As you could already realize that UNHCR engagement itself could help promote the research uptake because we work directly with the communities who is the beneficial of the research product. However, we are not a research agency, as you also know. We work very closely with the research entities, academics, NGO partners to try to see that how the research outcome would be applicable to the people we serve, but also in general, broader public health community in the humanitarian setting. So for now, the challenges I would like to highlight more from the global aspect. We have had some challenges at the local, so I try to complement from my experience at the global level. Firstly, what we saw that often when the research findings are not acknowledged or supported at the national level, it is difficult for us to implement that. As you know, we work closely with the government and we support the implementation of the program according to the national program and policy. So for any reason, if the research uptake is not taken up at the national level, it also hinders the implementation from our side. Now, in terms of getting the findings from controlled or specific contexts, which might often also limit applicability to the wider extent. So it is also important to see that if the examples that our findings are taken from a control setting, how it could also apply to a broader population, knowing that the humanitarian context is very diverse globally. I also agree with some of the points already have made in terms of the political stand and support. But what I would also like to highlight in relation to that, sometimes the cultural difference and local customs also had influence in uptaking the research findings. For example, the assessment we have done on family planning in multiple countries, including Asia and MENA region, we also realized that how it is important to engage men, to engage the religious leader, to engage the community in general, to get some intervention implemented that involve women. Otherwise, if we just include women, it will not get the highest outcome that we would like to receive, knowing the cultural practices. So that also relates to one of the questions I recall from the previous section. In terms of timeliness, this was mentioned in the previous session as well. We also have realized that often when we're very busy with responding to emergencies, we also try to see how we can apply the knowledge that are already available. But the time between the research finding and the policy or protocol development is very minimum. So we get very limited chance to really apply those knowledges. One challenge also I would like to highlight that often the research come as with the aspect of convenience. As you know that in many parts of the world we have refugees living in the camp settings. So it is easy for them to collect, select the samples in systematic manner, which is more into the convenience for the research study itself, but not necessarily the looking into the broader outcome of the result, which we always want to see how it could best apply for the larger population group. All in all, we know there are many challenges, but we also have realized that there are good commitment among stakeholders. Of course, we also have other discussion who they are, but in terms of the humanitarian actors, there is a very high commitment, including the national authorities, NGOs, and everybody. So we are hopeful that as we started speaking about that, we would make some achievement, even if it is low. Thank you.
Excellent. Thank you. I think you addressed one of the comments previously about the design of the research, which can help also the practitioners and decision makers, which is implementation science, which takes into consideration the context and how to adapt the interventions, which are proven to be effective in controlled situation into the local situation. This is extremely important, in my opinion. Thank you so much, Dr. Sultano. And now moving to the informing policy and practice. So Dr. Rinda Hamidi, I know that you are managing a very complex department and you are serving the majority of the population in Lebanon, and making those decisions that are making an impact on the population is not an easy decision. So can you please kind of walk us through to what extent you are basing those decisions on research, and how you are combining between the context and the research evidence?
Thank you, Dr. Gladys, for the introduction, for the question, and thank you for the invitation. I'm really glad to be among friends and colleagues and this group of experts, actually, and partners. So So I will answer you that given the fragility of the country and the context in the country, it's highly needed. Not only it's a need. We need to base actually everything we do on evidence, on research finding, even before the crisis. So what if a country is hosting more than 1.5 million non-Lebanese, serving them as we are serving the Lebanese in a primary healthcare network? I'm talking from a perspective of primary healthcare, by the way. So, and I would thank Dr. Zinia for correcting for Dr. Fuad that it's not that severe when it comes to decision making in the presence of politics and when it comes to political interferences, because he knows very well that sometimes we put it as a barrier for ourselves while it's not there. And the best example that I can give is the primary health care where we have more than 128 NGO in the country, and we all know that NGOs are all affiliated politically and religiously, and we can on the table, we could do it on the table of primary health care. We do not talk except the human health and the human rights and the equity and all things related to primary health care to reach out to every person on the Lebanese territory. So it's not always the case that we say that because there are political interference, we can put them on to our side and we can move forward with them in order to really make the right decision for the people. So I disagree with you, Dr. Fuad. I totally respect what you have mentioned, but I fully disagree with you on that. So, for instance, I can give examples from what we are serving and what we are doing and practicing in the primary healthcare sector, where we select medication, part of the essential drug list, the inclusion of vaccines in the national immunization calendar, and the development of new ministry strategies that shift the healthcare system toward primary care or rely heavily on research findings. So using data and information provided by research ensures that decisions are well informed and have the highest potential and positive outcomes. However, it is really crucial to use research findings strategically, considering the context in which they will be applied. Also, Zinia mentioned things related to maybe findings outside the country. I cannot just bring it in and use it in the country, because an evidence-based intervention that increased immunization rate in Sudan might not have the same effect in Lebanon, or even in the same country. What would make really effect or an impact in Akkar might not make the same impact in Beirut or in Mount Lebanon or elsewhere. Same, the best medication for diabetes in general might not be suitable for a specific patient, and a financing mechanism successful in Germany might not be like the World Bank. Sometimes they try to impose some financing mechanism outside the country that they are great for Lebanon. So it's not the case. It needs to be context specific and tailored according to the specificity of the country.
Mm-hmm. And even when it's tailored, there may be some feasibility challenges at times, which we probably, it's not just cultural, it's human resources, non-human resources, what have you. So there are a lot probably that we need to take, and these are evidence-based, like we need to research them. We need to find out whether they are being translated into practice and why not. And this is very informative, I suppose. Thank you so much, Dr. Hadi. Dr. Bahoud. So as the director of IFI, and we would like to know whether, to what extent research evidence inform and guide policy making processes that would address the challenges of refugees. So I know that you have a lot of extensive seminars, training, and capacity building. So can you tell us, please, a little bit about your experience from in that sense.
Sure, thank you. Good morning first, and thank you very much, Shadi, Dr. Saleh, for inviting me and for putting IFI on the stage here in this important discussion. And allow me to commend the fantastic work that GHI is doing, not only on this issue, but on many other issues of public health, of global health, and other crucial topics. I would start by maybe very quickly commenting on the headline of this conference. I mean, the subtitle that was putting a global crisis with local solutions. I think it's also a local crisis sometimes needing global solutions. So in fact, the local global is something very interesting to put at play here. And especially when we talk about a crisis like Syrian refugees, and more than that, the Palestinian refugees also, that is becoming in Lebanon and elsewhere a protracted and chronic crisis. So we're talking about long-term things. And so it's local, global, long-term, and also multi-layered. It's political, humanitarian, sanitarian, economic, sometimes geopolitical, etc., etc. So this is why it's very complicated and very complex. So to answer directly one of the two questions, what are the challenges and the impediments? I see very quickly three without getting into polemical discussions. The first one, you know, if you want to have evidence-based approaches, you have to have evidence and you have to have data. So the first lack, I'm looking at you, sorry, but is the lack of data about refugees. You just mentioned a figure, 1.5. Okay, I take it, but it's not the only one. My government, which I'm obliged to take seriously, at least because I'm working in an institution here, says 2.5 million. UNHCR, who is a very solid partner of IFI, and I thank you, I'll talk about it, does not give an exact figure besides the registered refugees. So we're in the midst of a sort of cloud of uncertainty. This is the first impediment, and it's not only pertaining to refugees. Okay, in Lebanon we have this famous say or infamous say that says that figures are an opinion, al-arqam wajhat nazar, which is something we have to deal with. The second impediment, which is related here maybe to what Dr. Fuad has said, is the shrinking or unhealthy policy space in the country. We have a caretaking government for the last 2 years. We don't have institutions. We don't have proper bodies of public policy to work with. So the public policy space, what we call it, how we call it in our jargon, is something not only shrinking, but sometimes dysfunctional. And the third impediment, which is related to that, is the lack of interlocutors. At all levels, okay? I can give examples on the financial economic crisis in the country, but we're talking about refugee health. For example, one of the things we have been struggling with at IFI is that we don't have proper institutional, formal, recognized, legitimate interlocutors in the refugee community itself. So when we do a focus group or a webinar or a seminar or a round table or anything or a workshop, we don't know whom to invite on behalf of the refugee community, and this is a very risky thing to do or not to do. So these are the three impediments quickly. Now, given that, we are doing things at IFI, and what we are trying to do is many things. First of all, the refugee program at IFI has been, for a while before even I took the lead of this institute, one of the flagship programs of the institute. It has been there for a while. It has started with Palestinian refugees, but then when the Syrian crisis compounded this catastrophe, we have plunged into that issue. And we have been proud, I think, even before I came to IFI, to be publishing regularly for years the fact book on refugees that was largely distributed in the country for policymakers, for media, for NGOs, etc., which aim was to mainly dispel certain cliches and certain toxic discourses about refugees. This is one thing. The second thing is that, as you said, and this is our bread and butter at IFI, we do policy dialogues. And policy dialogues are not always public and flashy. They are discreet, they are sometimes closed, They are restricted. They are sometimes hard to manage because they are conflictual. And this, we do it with the stakeholders. And here, to come back to what Dr. Fouad was saying, who are these stakeholders? They are really multi-layered. We try to talk to the refugee community. We have a constant and very positive dialogue with UNHCR. We have a constant dialogue with UNDP. We have a constant dialogue with other ministries, for example, the Ministry of Social Affairs and formerly the Ministry for Displaced Persons that has been now cancelled, with UN Habitat and with other international consortiums on refugees. So this is one thing we do. The second thing we do, and I think we can take pride of it, and we thank you for that, IFI is today, until today, the secretariat of a very large network that is supported by UNHCR, a network on displacement and refugees that puts something like 25 organizations, CSOs, institutes, universities, USG and others, on the issues of livelihood, protection, social coverage, medical care, education, etc. of refugees, trying also to have a dialogue with local communities in Lebanon, with which, and we have to say it plainly, with which this discussion about refugees, not only health, but all other issues pertaining to refugees, is sometimes very bumpy, very hard, very conflictual. You know that the crisis is compounding in the country. There's a lot of scapegoating, of hate speech, of things that could maybe turn, God forbids, into negative effects and dynamics. And on this level, we are very happy to do this work with UNHCR and trying to push it forward. Last but not least, we are also members of the Boston Consortium on Displaced and Forced Migration, on displaced person and forced migrations, which is going beyond Lebanon on these issues. It's a MENA thing. So we are also trying to take the knowledge that we are gathering on refugees in Lebanon in order to have a better understanding of these dynamics in the region, because as I said in the beginning, and it's my last word, it's not only a local question, it's a global question, and things pertaining to refugees and to everything human cannot stay where they are. They have an effect on the immediate and the more remote environment. So this is what we modestly try to do at IFI. We are not a do tank, we are a think tank, but we are trying as much as possible to use the thinking and the knowledge that we can, let's say, derive and brew in our institute in order to inform policy, and this is the part of the do that we don't exactly do. Thank you.
But you do have a role in consultancy and so on, so I think you will probably convey those messages to the decision makers.
And this is what we do with UNHCR, with the government, with international donors. We had, for example, lately a very heated debate with the European Union on this issue after the visit of Mrs. von der Leyen to Lebanon and this famous $1 billion package, which is not a $1 billion package, but it's okay. So yes, we have this debate with a lot of stakeholders. Again, it's not easy because of the objective impediments I cited in the beginning, but also because of the very polluted, I would say, political climate surrounding this issue. And I think that the worst is still to come in a country that is increasingly dysfunctional at all levels, with a shrinking, as I said, policy space, policy debate space, but also a shrinking economic space in the country, with a crisis that is hurting today all segments of the Lebanese and residents in Lebanon population.
Amazing. Thank you so much. Thank you. So, Ms. Lina Abu Habib, we need to talk about how we communicate and disseminate research. Obviously, this has been mentioned by our presenters and also by our panelists, is how to make the research kind of easy to digest among the practitioners, among the decision makers. So given your role at the Asfari Institute, and given your research background, can you tell us a little bit on how you package research to make it more palatable for decision makers and policy makers? Lina?
I was muted. Thank you, Gladys. It's a pleasure to be with you and with colleagues to discuss this. And perhaps in my 5 minutes, I want to focus first on what is it that we're trying to communicate and why is it complex and not at all straightforward. In the work that we're doing, and I want to remind us that the Asfar Institute was set up, created at the onset of the crisis in Syria, and therefore working on the Syria crisis and its consequences, notably the growing refugee crisis is one of our main and key pillars. So what is it that we're trying to communicate through research, and to which stakeholders and in what way? And I want to mention here that our emphasis is to look at, to research the gendered impact of, I'm going to use the Syrian refugees as our main area of concern. So the gendered impact of that conflict and the subsequent forced migration. And in the early days, in the 80s, we used to, when we were doing a gender analysis of poverty, we would say that poverty has the face of a woman. Now, if you look at all the imagery of refugees, what we will see are women and children. And I think despite the data that we have of why is the overwhelming majority of refugees, why are they women and children, we still do not have their voices informing research and subsequently informing policy making. A couple of years ago, with a colleague and a friend, Dr. Faisal Qaq, we did research looking at the lived experiences of refugee women in the Bekaa, Syrian refugee women in the Bekaa, and the way they understand and define their sexual and reproductive health, and the way they understand and define their own experiences of gender-based violence, looking at menstrual health, looking at conflict-related sexual violence, and looking at all forms of oppression that they experience because they are refugees and because they are women. And also looking at the growing trend of transactional sex, which refugee women and girls have to deal with. And we realized that actually there's very little, there's a serious knowledge gap and a serious research gap when looking at this. And even when you have this data, your stakeholders, and I think Cordelia and Fuad unpacked, the complexities of stakeholders, many of whom do not have the bandwidth to listen or to absorb communication on conflict-related sexual violence, sexual and reproductive health, and menstrual violence amongst refugee women. So having said this, how do we communicate this? And the other impediment to this communication is our assumption that refugee communities are homogeneous. They are a block. Without realizing that there are layers of power relations amongst and within refugees, without putting on an intersectional lens. And once you put an intersectional lens in your research, how do you communicate it to stakeholders that are truly gender blind? On the one hand, that's the main impediment, and I want to cite an example where we were talking about sexual and reproductive health at AUB, and one of our external guests just started by saying gender equality is too divisive and problematic, and let's not talk about it. That was the idiotic statement with which this person started, which basically undermines the whole analysis and understanding of how do we perceive, how do we analyze the gendered impact on refugees, and therefore how do we undertake policies, and what kind of communication can get through some incredibly racist and incredibly sexist and incredibly homophobic minds amongst policymakers. And I want to circle back here to my friend Dr. Fuad, because he pointed out to a very important problem, the elephant in the room. Policy making in Lebanon and also in countries in the region has always been opaque, has always been corrupt, has always been oblivious of facts, and has always been patriarchal, homophobic, and exclusive. So unless we realize this and unless we acknowledge this, we are going to continue reproducing policies which are informed by anything and everything and personal interest, but not by the rights of human being. So based on this, there are many challenges, and I think one of the really important channels that we have found is that research findings and which come out from the kind of research that we do is mostly around the lived experiences of people, the lived experiences of the most vulnerable. And as I said, the most vulnerable, I'm talking about women, I'm talking about queer refugees, refugees with disabilities, I'm talking about various ages and the oppression attached to every age, and I'm talking about the intersections of all these vulnerabilities. The first and foremost way is to be able to create spaces for people within refugee communities to share their lived experiences and basically to have the confidence and the power to share their experiences. And that has been the first and foremost. The second aim is what we call in social movements, who are your allies? And same as I say, you know, refugee communities are not homogeneous. Also policymakers are not homogeneous. And luckily not everybody is sexist, racist, and homophobic. There are entry points within policymakers of people who can be allies and who are able to basically take on this message, these messages. And the third one, looking at social movements for transformation, social movements for social justice and for human rights. We don't exist in a vacuum. We're not, and that has been a struggle, a historical struggle, that such movements for social justice, they're not isolated in their little countries, and they're not into cultural specificities. And therefore, another powerful communication is at the global level, is the ways in which we use these findings to serve as communication messages in global advocacy fora. And maybe I want to add by saying every time you know, and I probably Dr. Fuad, who has the most experience of working in the field with refugees, every time you talk about this research and every time you talk about this work, you are faced with racist comments. Why don't you look at the host community? Of course, this is factually wrong. Everybody is looking significantly at the host community. Why don't you take into consideration that Lebanon and the Lebanese population is tired and affected by the economic crisis? Of course, this is very true. But Syrian refugees in Lebanon, and I would argue women and girls refugees, queer refugees, disabled refugees, are actually being attacked via hate speech. And this is particular to this particular group. And unless our communication includes this particular vulnerability and how it is a major challenge that actually affects their health and their mental health and their sexual and reproductive health and their menstrual health, and the fact that they are victims of specific human rights violation of oppression, we will not be able to construct the policies that will transform their situation. I'm not going to say improve, I'm a little bit more ambitious. Thank you, Graciela. Thank you.
Thank you, Lina. Obviously, you had given us a multiple kind of, challenges that are facing the research from a gender lens, obviously. And you gave us a lot of food for thought. But it's interesting that when we are researching women, and we go to the field, to the actual people, they are so vocal. They understand the situation so well. So let's not undermine their opinion, because they have really a good understanding of not only their health condition, but also the cultural things which are in relation to gender, and also the social aspects of family and so on. So I probably would agree with you that there is some sort of a narrative that could be sexist, but we are trying to empower these women as much as we can in our research, and hopefully when we are trying to package these findings, we need to get back to the community and tell them these are our findings. And this would be an important feedback to them, so that they will understand how their society is being perceived by us as researchers, so that we won't be in an ivory tower towards them. We need to put them on the agenda of making their own decisions, and they have the power to do that. So let's not undermine them at all.
Can I just say something? That this is exactly what I was saying. And by using feminist epistemology in research, you are bringing back the power to the women, to the girls, to the queer folks themselves. So basically, any kind of policy making is based on their voices and on their lived experiences. That is the main difference that we are trying to bring in, and creating the spaces for people who are affected by the conflict and by displacement to amplify their own voices and not through us.
Yeah, absolutely. And I must say that at GHI and RHP, this was kind of the motivation for us for conducting research from day one. We wanted the community perspective, regardless of their gender, regardless of whom they are in the social system, and that's exactly why we are here 7 years later. And mind you, that our research is being picked up by the global community. I was in different conferences presenting our studies, and people were interested in us, what we are producing as knowledge. So it's not just the global north which is producing this knowledge, it's also us who are producing it in the big time as well, and very influential for people who are on the Texas borderline, who were asking us, how do you deal with the refugees? I remember very well this question is like, they have the same problems as we do, but it's a different context, it's a different population. So let's not undermine our research that we are doing in this part of the world. Thank you, Lina. Dr. Hamidi, going back to the capacity building, we know that when we are producing, and you mentioned it yourself, you are basing your decisions and priorities based on research, but then you find out that we have certain shortages in the way we are delivering services at times, and I work with you a lot on those things. So the capacity building initiatives that we are doing, are we making a fair kind of interventions for the people who are doing this work, and also on the receiving side? So what do you think about the efforts that we are doing in Lebanon?
Thank you. Thank you. It's very enriching, actually, this session, and it brings to my mind so many things that I need maybe to work on more in details when it comes to capacity building specifically. But before addressing this part, let me tell you that when it comes to research at the primary healthcare level, we're working on implementation research. And this is now really producing very good, I'm not saying too much, but I'm saying kind of enlightening the path for us in order to discover where are the gaps and how to bridge those gaps when it comes to service provision and needs of the population. And I always say we don't have to build the most sophisticated and expensive model. However, we need to tailor it according to our capacities and to the needs, and how we can get there through the evidence that we need to generate. And that's why now the implementation research that we are doing are accompanying the different projects that we are running. and that we are implementing, so that we have quick fixes while we're implementing. And from the evidence that we are generating, maybe regularly, we can do the quick fixes that would respond to the need of the population. And when I say population, it means everybody on the Lebanese territory, Lebanese and non-Lebanese. And when it comes to capacity building, also this is also yielding there the needs of what are the topics that are needed when you talk about the capacity building. And I can tell you that the resources are always scarce when it comes to whatever kind of resources that we are talking about, being a human, financial, time, because we're fighting against, the time is not a luxury for us. Every day has its challenges. And when you are dealing with the field, with the community, with the day-to-day needs, you can see that it's always, running, and you cannot get whatever you want, and you cannot respond to the needs because it's really huge. And accordingly, the capacity building to respond to those needs are not enough. We are always in shortage of the things that we do. That's why when we address UNHCR or donors, UNICEF, WHO, we always dwell on this specific part, which is the capacity building. However, it needs to respond to the real need, and it doesn't have to be dealing with sophisticated topics or issues again. So what we are doing is at the ministry level, we are using the capacity, the national capacity that we have through the committees, the expert committees that we have in different programs. We are collaborating with academic institutions, and the collaboration that we have together is a very good example. Evidence-based guidelines, developing regularly and updating guidelines and protocols for healthcare. And the most recent one is the clinical algorithms, and all falls under the LPSP, which is the long-term subsidization protocol, which is a real milestone that we've done at the level of the country, where we have a national protocol now dealing with the service provision at the primary healthcare level. Data collection and analysis, stakeholder engagement. So these are all things under the capacity building and sharing those knowledge among everybody.
I know that you're making an impact, so let's not be very humble about that. You're doing an excellent job in terms of using research. I know that for a fact. Absolutely. Thank you. Last but not least, we're going to be discussing a little bit the impact of research uptake. So we want to know from perspective of the regional and also local international organizations that are functional in Lebanon, on what are the monitoring frameworks that they use for measuring the research uptake. So Dr. Ardalan, can you give us examples or walk us through the monitoring and evaluation process that you follow at WHO?
So basically, if you allow me, just I want to actually reflect on some of the parts that the other speakers mentioned, and basically a little more detailed the big research, the question that we have on the importance of the research and translation into the policy and practice, especially in the context of the humanitarian situation and the refugee health in particular. I also want to emphasize on the importance of the context. So basically, the context would define many aspects of our work. If the context is like a limited camp setting, or the context is the actually refugee living with the host community in limited area, or we are going to basically talk about like a country policy making to address the issues of the refugee health. When it comes to their health services they are going to receive, the renewation of their residency situation, etc., etc. So there are many socio-political, economical issues to be considered. So this is one aspect. The other aspect is about the research term per se. And so when we talk about the research and evidence, for sure we are not talking about the same thing. It's about what type of the research, what type of the evidence, with what quality, what the level of the actually evidence. Is that scattered evidence somewhere, or is actually synthesized evidence that is acceptable by, for instance, a large group of the stakeholders? Is about the evidence produced by the RCT, and it is a known, for instance, vaccine that we are going to implement in some context, or it is deciding about implementation of the service package, H3 for instance, in northeast Syria, in a country with somehow fragmented governance. So these are the things that actually I think at the end, when we talk about the utilization of the research that we need to take into consideration, and I think all of the fellow panelists and speakers somehow mentioned. So coming to the monitoring, if that we are monitoring the use of the research and their impact, basically what I'm aware is that the initiatives that also some my colleague mentioned in the WHO that are highlighted, basically making sure that the use of the evidence is being into consideration for all the project design, their monitoring and evaluation. So that's the so if the question is that basically that particular evidence is being used in that project, I'm not aware of such basically monitoring system in place. Okay. However, what is being done is that monitoring of the aggregate actually indicators of any particular initiatives. Assumingly, those indicators are defined based on the actually acceptable evidence, based on the consensus in the actually initiation of the project. So this is would be a short answer to your important question. Over to you.
Okay, thank you, Dr. Ardan. Obviously, it's a very complex situation to be monitoring and evaluating projects. Dr. Sultana, any insights on strategies that you use at UNHCR to promote research uptake and to monitor the uptake and its impact on the population?
Thank you, and again, thank you all the fellow panelists. You see there are different perspectives, and of course we always know that issues related to Syrian refugees are often contentious, so I would not go into that. Let's focus into the point of good practices. I would also rephrase that in terms of innovation. Some examples that we have from UNHCR, again, global experience can be fed into the local context, and I believe the local context could do the other way around. So to start, firstly, with what we promote or favor is to have open access journal for the humanitarian research findings, so that it is accessible to all, and that would help disseminate first to those who would like to get access to these findings. Now, if we are talking about the different methods of dissemination of research findings, we know them all, including the dissemination seminar, webinar, etc. But what we also do is that we try to combine often the research findings with field experience. so that it is more comes into the practicality of the findings for the higher uptake. One example I could also give is in terms of the projects that are more that have more chances for scalability, which have also higher chances for uptake. So of course we know that all the contexts are not the same, but if I would like to bring one example from Uganda, where we have South Sudanese refugees, we had implemented a self-help trial, engaging the very minimum level of technical support, which we saw that was expanded very rapidly to the community. So local involvement, low-cost intervention, I think they always have the higher chance for uptake. Often we also see the academic findings are not well translated to the implementation. So from UNHCR side, what we try to do with our partners, so of course WHO, UNICEF and other NGO partners are there, we try to operationalize them, and we prepare kind of operational guidance from the findings, so that the people who are on the ground, particularly program managers, health focal points and the other stakeholders, they know how to utilize them. So yeah, I mean, there are also tools are developed from the research findings, and that would be easily available to the people on the ground for utilization. So those are some of the good practices, might not be very innovative, but those were success in our different settings in the world. Thank you.
Thank you so much. I know knowledge translation and knowledge uptake can take like probably a year of training to be done. Honestly, I was involved in several courses about knowledge translation and knowledge transfer. So, and there are lots of models that we can adopt. They are evidence-based models for knowledge translation that we can probably adapt or adopt in our context. I believe that we barely scratched the surface of this important topic, and hopefully we were able to kind of eclectically have this kind of understanding. So in a nutshell, the research that we are doing, we need to be translating it in any way possible. You mentioned about low cost, low resources that we can have to be able to implement them, which can have a higher impact on the population is important. So we need to consider those when we are doing research as academicians. And also we need to be taking into consideration the multiple contextual factors that our panelists have addressed during this discussion. I personally would like to thank every one of you for your input. I know that we did not give it the fair time to be able to discuss in more details, but this is the beginning of a dialogue that we can pursue it on a long run. And let's keep it into consideration whether we are in a practice or a research or any decision-making situation, that this is an important dialogue that we need and link between research and practice. Yes. Yes, of course. We're going to be opening it for questions. Go ahead, please.
Yeah, thank you so much for very rich interventions. I'd like to speak about 2 points. The first one, how much it's really important whenever we're doing that, especially in a protracted crisis, and where we know that the socioeconomic challenge has really been very big, and the tolerance of the people is very low. How much ethical research is extremely important to ensure that whenever we're doing data collection, we're always providing a service in retrospect, because some people don't have food on the table. They will not provide data easily because they have other priorities. So we're seeing this on the ground, and we're always making sure that whenever data is collected, there is a service provided in retrospect, or at least validation, or they feel part of the challenge. And we know that now in the South, no data collection is allowed for security reasons. So also there are lots of constraints that we need to look to ensure that the data really is relevant. And
so
I know.
Just address one question at a time so that we'll give it
Yeah, just a reflection, not a question. Actually, I wanted to that we are not always too hard on ourselves. We know that Lebanon passed through all the type of emergencies in the last 5 years, and despite everything, really a lot has been done. And especially the COVID and lessons learned from the developing versus developed countries, it showed that developing countries who are used to complex emergencies did much better in terms of response. And this is where we really need, not because Dr. Hamedi is here, but really the Ministry of Public Health did wonderful in a time where we have very limited resources, a very high brain drain. The flexibility that's provided, especially at the level of PHC, in terms of allowing PHC to buy now what we're seeing in the south, non-communicable diseases, having the satellite units, allowing the PHC to do stitching and burn dressing, etc., to address. I think this is worth noting, in addition to the cholera and how much really there was a fast reaction in terms of containing it. So I think the MOPH needs to be studied as a success story of how much, with all the difficulties, a lot has been done.
Thank you so much. Any comments from the panelists about the first question?
عامل association. My question is, Dr. Randa, I know that a lot of research is going to MOPH. How do you prioritize which research to move on with at the level of the primary healthcare network?
Thank you, Dr. Ziad, for the question. I think this is a bit early because we need to discuss it together. We need to look at the outcomes and discuss together, since we used to work all together under the National Committee of Primary Healthcare with all the different partners. So I think we need to give it a good time to sit, discuss what are the priorities, and I promise that we will do it together.
Thank you, Dr. Hamidi.
Hi, I'm Diana from the Bioethics Program at AUB. I just want to ask, a lot of you mentioned the limited resources as the common problem. And I'm just wondering, so how are funding entities or perhaps governmental entities, what are they doing to enhance collaboration between the different sectors? Because you mentioned that in order to make research uptake more efficient, you need to have collaboration between the sectors. And when there's more collaboration, you decrease the need for more resources because you decrease duplication of efforts. And when institutions are working independently, they're using these same resources perhaps to do things that should not be duplicated, which can save a lot of time, effort, expertise, etc.
Yeah, thank you. So networking between the different key stakeholders and gathering resources so that they will be kind of channeled. Any comments from the panel?
At the country level, there is a body who's really leading this at the level of different ministries. Ministry of Social Affairs has a key role, Ministry of Public Health, Ministry of Finance. At the cabinet level, there is a body leading this, and different ministries are feeding into the different, sector that they are leading. But I don't think now it's the time and the appropriate time to explain about it. Definitely there are gaps, definitely there are things to be improved. However, it's not maybe the scope of this meeting to talk about it.
Thank you, Dr. Hamidi. Yes.
Okay, bonjour, Dr. Youssef Shahimi, Madar Quality Supervisor. أنا عندي سؤال, my question for Dr. Ali. So we were talking about, first, we know, as mentioned before, that academic or the researchers and academic papers can take years to become evidence-based. So, and as Dr. Ahmedi mentioned, and I totally agree with, that the implementation of the response to X crisis can differ from country to country or inside the same country. So taking many variable human resources, dynamic, geosocial, political, etc. So the time that for the study to become evidence-based during the process, يعني for me as a doctor, for taking the evidence-based medicines is to have the optimum for the practice related to X or Y case. Let's say it's a little bit not static, but less dynamic than what we are discussing now.
Okay.
So my question is the time the process takes to become evidence-based. The strategies or the approved evidence-based can be negatively affecting the donors who are from, let's say, from wealthy countries and not living inside the crisis. To agree on proposal or on the implementation way to work or on a problem or crisis. So how in our research or policies before being globalized can take this into consideration?
So usually evidence-based doesn't have to be, recreated. There is a lot of evidence out there that we can use. Now, if you're working programmatically, then the program can take time. But then if you're working in an emergency situation, often what you need to be following is whatever is already given in the global community. As Dr. Sultana was saying, let's not ignore that there are other settings which faced similar situations, so we can learn from them. But if you're working within a program and you're creating this evidence, it becomes kind of, you have the luxury of time. So there are nuances between what you are trying to achieve and how the evidence is available. So let's not, it's not like a one pool of things. There are different aspects for the uptake of research. Okay, sorry, but I think we're running out of time. Maybe we can have a side chat, like, when we finish.
Thank you, everyone. Thank you all. We have now reached. Thank you. So we have now reached the end of the Global Forum on Refugee Health, and I would like to say thank you again to all our speakers and panelists. Thank you to all attendees for your participation, and we hope to see you at future events. Please join us for lunch reception outside. Thank you.